Welcome to the third webinar of the CCCM COVID-19 webinar series with the topic of adaptation of CCCM activities in urban neighborhoods and informal sites. So this webinar has been organized by the Global CCCM Cluster Area-Based Working Group, which is co-hosted by NRC and IOM. So my name is Ash. Could you change the slide, please? So my name is Annika Grafik, and I'm part of the Global Area-Based Working Group and the IOM CCCM Support Group team. My very dear colleague Giovanna Federici, who is the chair of the working group from NRC, unfortunately can't join today, but she's sending her apologies. So thank you very much for you to make time to join us today. And before we begin, just the technicalities, please mute your mics and your camera for the moment. If you could introduce yourself quickly in the chat and say hello. And then later on for the discussion, if you want to type in your questions into the chat box, and then we will get back to them. So this webinar is also recorded and will be available online later on. So today we will have two presentations from Somalia and Afghanistan. They will be about 15-20 minutes. And then we hopefully have about 30-40 minutes for discussions and questions which were raised. So next slide, please.
8:45, right? First class?
I can hear that I think some people may still have their microphone on. If I could just kindly ask them to mute it. Thank you. So this is the third of the CCCM COVID-19 webinar series, the CCCM Tuesdays. We had already two webinars, 2 weeks ago by the Participation Working Group on community engagement and participation during response to COVID-19, and last week by the Capacity Building Working Group for remote training or training remotely, sharing of tips and best practices. Both of them are available to listen to online on the CCCM cluster website. And after today, there will be two more webinars coming next Tuesday on digital communication with communities in remote programming, and then the following Tuesday on remote management challenges in engaging with state and non-state actors. So our discussion today will focus on how camp management activities are being adapted to COVID-19 outbreak in informal sites and urban neighborhoods in Somalia and Afghanistan, where IDPs often live in small, scattered informal sites, often on private land or in urban informal settlements, intermixed with host communities or other very vulnerable groups like the urban poor or migrant groups. They are often at a greater risk to suffering from the COVID-19 due to the overcrowded living conditions and lack of household sanitation and water supply, as well as waste management. It's already very limited access to public health services, and their livelihoods is often or predominantly based on daily labor in informal sectors. So social distances and physical distancing or isolations are at best times challenging or maybe not achievable. So within this context, I would like to introduce our two speakers, which I'm very happy to have here today to join us. So our first speaker is Bagossy. He's the camp management specialist for NRC in Afghanistan. and he will be talking about NRC's urban programming in informal settlements in Kabul provinces and also in other provinces of Afghanistan. And our second speaker is joining us from IOM Somalia, and Abubakar Ibrahim is the IOM head of sub-office and CCM cluster focal point for the Baidoa region in Somalia. So thank you very much to you two for joining us today and sharing your experiences with us. Before I hand over to Mate to talk about Afghanistan, we have received quite a few questions which you have sent in with your registration. And I have collated them into kind of several topics, of which you can see here on the slides, such as risk communication and community engagement strategies within informal settlements or urban areas, working with local governments and private landowners, or the challenges of physical distancing and social distancing in densely urban areas. And you can see further the lists. So our two speakers have also seen these questions, and as much as possible, they will try to refer to them in their presentation. And any other questions you may have or you would like to pose, please type them in the chat and I will look at them during the time, and then after the two presentations we can come back to them. So I will now switch off my camera and ask Mate. I'd like to hand over to you and switch on your camera if possible, and looking forward to your presentation.
Thank you. Annika, can you hear me?
Yeah, we can hear you fine, thank you.
Thank you. So there is some echo, but I think that's normal. So thank you very much, everyone, for being here today in this seminar. I will try to present an overview of what we do in Afghanistan, and then how COVID-19 has had an impact on different levels in the country and especially in the urban areas, and then how we are trying to adapt, and finally what we are planning for the future, which additional ideas we are thinking about implementing in partnership sometimes with other actors, of course. So in Afghanistan, there are not many camp management service providers. Actually, we are right now, since 1st of January, the only significant one. And we manage, as NRC, informal sites in the west of the country, with a total population of around 120,000 people. And then we have, yes, thank you, that's the next slide, yes, thanks. In the north, in the west, we also have, so in the same region, besides the site management, we have an area-based approach, sort of pilot in Badghis. We target around 8,000 people. In the north, we have another area-based approach component, UDOC, we say urban displacement out of camps in NRC. It's similar. We target another area with around 8,000 people. And in central Afghanistan, in Kabul, we have 5 UDOC centers targeting more than 23 informal settlements. So officially Kabul has around 60 informal settlements, and we are present in nearly half of those through 5 centers. We cover around 40,000 people, and we are planning to open very soon. It was planned in these days 2 other centers, but we are delaying this, seeing how the situation evolves in Kabul. So I think we can go to the next slide, which is this is a little overview. This was an overview of our program in Afghanistan. our programming in urban areas, we work in Kabul, of course, is a very high density, but also in the other locations we work is a pretty high density of population. Our 4 axes, nothing surprising for you, will be information provision and two-way communication. Yeah. Protection. So maybe this is, I don't know if surprising, but this is one of our specifics in Afghanistan, is that in several regions, protection teams are under camp management, which has its advantages and disadvantages sometimes, but so far is going pretty well. So we do protection mains, like referrals, we do even individual protection assistance, we do safety audits, we do a lot of things. We have the community engagement and organization of the communities. We form committees, similar. So we use, as you know, or as many of you probably know, camp management tools and practices applied to in a certain urban area that we try to define in basis of a high density of vulnerable IDP, displaced returnee population. And finally, we have another clear aspects of our mandate, which is the core field coordination of the different service providers, that we also do with in a quite successful manner in urban areas throughout the regions we work. These activities are done from community centers that cover an area. Usually an area includes several informal sites, and through mobile outreach teams. Of course, we have male and female staff, 50-50, and we have been able to build a quite good outreach and relationships with the local communities in the different areas. Yes, and I think I will go now to the next slide, please, which is the impact of COVID-19. Now, Afghanistan, if you look at the overall numbers, I don't know, from Johns Hopkins or WHO, we don't have a lot of cases right now. We have around 1,000, between 1,000 and 1,100. Now, this is certainly an underestimation, like elsewhere in the world as well. But Afghanistan is very, very exposed. Is exposed because its proximity to Iran. Iran being one of the first countries with the most number of cases. There is a very porous border, and also the border hasn't been closed until now, in fact. So we have seen, I cannot tell you a number, but we are talking about tens of thousands, possibly a couple of 100,000 returnees from Iran to Afghanistan. So most of those returnees have escaped Iran because, or not escaped, but returned from Iran, let's say, because of health risks, but because of loss of livelihoods. And many of those returnees represented the main, sometimes the unique source of livelihoods for displaced people within Afghanistan. So they use, as a survival strategy, they will send one of their... sorry, there is a micro on.
Excuse me.
Could you please? Yeah, thank you. Thank you very much. So those this is interesting because it's a situation that, of course, in every country we are facing livelihoods issues, but this is a very specific situation because it's not only eliminates the livelihood, but it causes a lot of people coming back to sites and to informal sites and represent. So it's both a loss of livelihoods and one more person to kind of feed. Yeah. So we see, and I think this responds to one of the questions we would ask. People are not leaving informal sites, are actually arriving in numbers to informal sites in Afghanistan because they return from Iran and Pakistan, and because they are often evicted or they cannot cover anymore their rent within the cities. So they kind of go back to the settlements, which makes more further pressure. Only in Herat, we had in the last 6-7 weeks around 25 to 30,000 people going back from the city to the settlements. So we have big health risks due to these movements and these people coming back from Iran. The health system of the country is collapsed, basically, and the economic activities have stopped. And as you know, probably this is the same for many other countries. The massive majority of our beneficiaries are either daily workers or unemployed. So the daily workers are suffering a lot because those little trade and little jobs they were doing are first, well, they were kind of they disappeared, and second, after the movement restrictions were established in some cities like Kabul and Herat, they just cannot go out to do even a minimal work. And this is also an issue for humanitarian agencies. So we are having a lot of negotiations with the government in order to successfully obtain permits and be able to continue our work. And initially it was only health actors that were allowed, but of course after some advocacy they understood that they should allow us to operate as well. And is ongoing, but it's a little bit of a struggle as well. So this is also affecting our implementation. Moving to the next slide, which is probably the core of this presentation, is how are we adapting? Well, we expected we had some time to prepare for the situation, even though after some point there is, I mean, I would say that the margin of the freedom of movement is reducing and reducing. But our priorities is protecting our beneficiaries, protecting our staff, and remaining meaningful, remaining an added value. So try to transform our work in a way that we can continue doing whatever we can continue doing, and we stop other things, but we explore also other areas eventually, so that we can remain an added value. Now, this is a little challenging because our work is very much based in community centers. And, well, as the name indicates, those community centers often are a place of gathering. If we are successful, there should be a place of gathering. And we have had to establish rules. So that will be some of the first measures that we have taken, is to establish rules in community centers. I think this is quite normal regarding hand washing stations, but also as the situation has been deteriorating, we have provided disposable gloves and masks to anyone who is visiting, and we only allow a maximum number of people at a time in a community center, and with social distancing. So these are some of the classical measures, but we are really struggling to keep open those centers because they are very important. They mean a lot for the community, and we are thinking how we can hand over partly to the community, but we want to keep the health risks under control. So we really want to maintain a presence as long as it is feasible. Regarding our staff, they are well equipped. We have purchased all the needed material, and there is also this personal protection equipment, I think it's called PPE, which are there in case as well. And just a comment regarding social distancing. It is practically impossible. So we have some alternatives eventually, how to make some quarantine facilities, etc. But social distancing, as suggested by the guidelines, even though I have seen one guideline, I think it was from UNHCR, which was, I think, useful and good, but what we have received in Afghanistan was not not feasible, so not really practical. So we have basically one of the first measures we have taken is to give top-up cards to community leaders, but also to a lot of community focal points. including female committee members everywhere, so that we can have a daily communication with them. And we indeed maintain this daily communication. We have a schedule of calls through the committees, and we go through questions, and we monitor the situation in the field, and we ask them to monitor the protection situation as much as possible as well in the area. They know what they have to do, and we have our focal points for different issues. So they feed back information daily to us, and then we make the referrals, and we make the coordination with other partners. And this up to now, and it has been already quite a few weeks, it's doable through phone and the internet. So obviously the population has to be provided, or the focal points have to be provided with top-up cards. Otherwise they cannot do. So if the top-up cards finish, but I think this will not happen too soon, then we will have to find a way of topping up again, if we cannot move to the field. But for now we can go to the field. Yeah. But I think this phase will close soon. So we are implementing all those classical measures, and then we are using our outreach teams to make massive campaigns of awareness, and we have been the first ones starting this quite at the beginning of the crisis, around 2 months ago. We have been doing awareness in all the sites, providing information. Unfortunately, we cannot provide hygiene material by then, but now we are partnering with WASH actors to organize big hygiene kit distributions. Since social distancing is impossible, everything that we can do, it's, well, not everything, but a significant part of our possibilities go through providing WASH items, and due to the general food insecurity increase, we are going to be partnering as well with in a big project to distribute cash for food, because there is already some malnutrition in some areas, especially in the West, and this is going to increase very fast in this situation. So we go door by door up to now. I don't know how long this will be feasible, and we inform people, and by now we have reached all of our communities through awareness. So we stick brochures to places. Yeah, we don't give any more leaflets or things, just in case. And so far we have been able to collect good feedback through phone. So we are collecting a lot of feedback, and we are being able to refer it and create action. So in that sense of communication with communities and referrals and protection, we are managing, I think, quite well through those mechanisms. The more problematic is the committee meetings, but we are also we still organize committee meetings, but with a physical separation that we can enforce in the community centers. But those meetings are very small, so maximum 5 people, and we go through the issues, and then people leave. So we have taken those measures. What else? Credit cards, online coordination. Our staff have been signing disclaimers in some occasions, but not always. I think I have to go back to that. And I want to talk a little bit about the remote activities, maybe in the next slide already. So what can we do if we go fully remote? So it will be my last slide. The fully remote implementation, which I think will happen. Well, some of the mechanisms we are already doing, they work, and they should remain working with a fully remote implementation. But we have to. One of the problems we are finding is that there is not enough. There is a lot of rumors spreading. So we are now conducting a countrywide, all the humanitarian community, a CAP survey that will start in a couple of days. We did a significant input to that survey from CAP management. And after that, I think we will be able to know better how to tailor our activities. But for now, one of the main problems is the rumors. I don't know if in the other countries is also a big issue, but rumors, it's a very problematic already under normal circumstances in Afghanistan. and now they are just exploding. So we are partnering with, we have started these negotiations with phone companies to be able to have send bundles to thousands of households that we have registered, IDP households in sites, and communicate with them through this system. So we call it Smart Rapid Response Mechanism because it's based in a system that was created in case of sudden emergency, and we are partnering with our emergency team on this. And we are now going to pilot it in the West, but we hope that this system will be able to allow us to communicate with a lot of people at the same time, receive feedback. So we are negotiating with the providers so that the response or a limit, up to a limit, doesn't cost any amount for the beneficiaries because they are not in a situation of spending anything. And we are hoping also to conduct surveys this way, or eventually other activities. But we will start with rumors. So we will start countering rumors in partnership with the Ministry of Health, and they are quite interested in this. So we are now drafting the messages, and this is one of the main systems that we will use. Starting with rumors is a pilot, but if we see the potential, and I do think there is potential, we will kind of develop this more for a more generalized communication with communities. What we will not be able to conduct anymore is events, and the meetings will be challenging because no one in the field has internet among the beneficiaries, but we will keep this daily schedule of communication. So we are in a way I think already preparing for the full remote implementation. Another thing we have planned is, if it's allowed, is to have this mobile vehicle awareness through loudspeakers in sites. It's a very it's a traditional system, but I think it's quite efficient as long as we don't cause panic and people do understand the message. They don't come running to the vehicle. Because we had to close one of our centers because people were coming too much now, and then we reopened it after some awareness. So finally, to conclude, I hope I have not been too, I have been clear somehow, because there is a lot of things. I think our challenge will be to remain relevant, but as I can see the situation evolving now, we will remain relevant because there is multiple requests for information from us. People cannot communicate with communities because they don't have that information of who is the community focal point, how to do, like they are suddenly really confused, whilst we have already the information of most of our focal points, or all of them, and we communicate daily with them. So we can keep linking people and service providers, people between themselves and service providers between themselves. It just requires access to internet, at least for our key staff, and this has been provided, and to telephones for all of our staff. And as I see it, for the last couple of weeks, we are partnering with our legal assistance team for preventing evictions, and this is working quite well. With WASH, with food security, and all of them are using our contacts and the information we supply in urban areas to deliver. So I think so far I am quite happy how it is being, it is going, and I think we still represent as CAM management an added value and a positive value for our beneficiaries. And I think this is, of course, super important whilst keeping the safety of our staff. So I think that's all from my side. Thank you for your attention, and I'm looking forward to the questions and to the presentation by Abu, that I will take notes for sure. Thank you.
Thank you, Mate. Thank you very much for your presentation and for keeping to super time. And
yeah, I took my timer.
No, I mean, you did perfect time, I meant. If I could just remind everybody to keep the microphone on mute so we don't have so much background noise. And we would go straight to Abu from IOM Somalia office, who will be sharing his experience in their preparedness and response activities for COVID-19 in the informal sites in the Baidoa region. But please type in your questions into the chat. I can see at the moment one question has been put in, but so we have plenty of time to get back to more questions. So Abu, can I hand over to you? I will switch off my camera and let me know if there are any problems. Thank you.
Thank you very much, Annika and Mate, for the wonderful presentation. And thank you all for joining this webinar on how we are adapting during this time of COVID-19, our work in informal settings in the sites, especially in Baidoa. It's an unprecedented time. I mean, we are all in the learning process, so my presentation will be touching more on what we are doing right now, but I can assure you it will be changing. The picture that I put here is a typical site in Somalia, just to give you an idea on sites that we work in. There are no planned sites or camps in Somalia, especially maybe less than 10%. The majority, this is informal sites that we work in. Next slide. To give you a bit of a background, in Somalia, we have about 5.2 million people who are in need of humanitarian assistance, and approximately 2.6 million are IDPs, and majority of these IDPs live on private land, meaning there are no public sites designated for these, for them to reside in, and this has its own issues, which we will come and cover later on. These sites, most of the living conditions is overcrowded. They're in a makeshift shelter without the bare minimum basic services. We have about 2,000 IDP sites as per the cluster numbers so far all over Somalia, but I can tell you that this number keeps on changing. We keep on doing service site verification every quarter, and this number keeps on increasing and increasing. In Somalia, the CCCM cluster is one of the new clusters that has been activated, and it started in 2017. And given the few years it has been in operation, I'm quite happy with what has been covered so far. Next slide. IOM, like in any other areas with UNHCR, we are co-leading the cluster, and all these 2,000 sites I'm talking about, we have about 12 CCCM partners across 14 districts in Somalia, and they've so far, tried to reach about more than 700,000 IDP sites, households living in IDP sites. Next slide. So the way we are working right now, CCCM, from the onset of the COVID-19 crisis, what we've done is we've decided to bring on board everyone as we do coordination with the local authorities, with the line ministries, especially Ministry of Health, Ministry of Water, and other humanitarian actors using the cluster focal points to, sort of bring everyone together. So we've made sure we have our CCM partners, WASH partners, and health, and decided this is not going to be a way for only CCCM to sort of pass messages or, combat what is happening in the site, but rather a coordinated and integrated approach from all partners who are present at sites, but also with the local authorities. This has been essential because we have so many sites. Like in the region that I work in, specifically Baidoa, we have about close to 500 IDP sites with a population of almost 500,000. This shows you the great magnitude of what we need to cover to make sure that we reach as many people as possible to pass messages. So working together jointly with other partners, it brings about our mobile outreach teams work together with teams who are hygiene promoters from the WASH. We have health partners who will discuss, issues of health directly. And this way we are like moving together, and it's much easier to even tackle issues that are coming up instead of referring it to a watch cluster after CCCM partner gets this information. And also it helps in terms of getting to send the same message to beneficiaries. But of course, without our frontline staff who are still present and working in these conditions, it wouldn't have been possible. So what we have done is, first of all, looking into ways of making sure that they have the correct information as per the WHO and cluster guidelines on COVID, making sure they know how to protect themselves, and also the correct message to pass. So even the trainings when we're doing health partners, WASH partners, and CCCM came together in one sitting, and of course through social distancing, and this message was, training was provided. We provided our teams with all the gear they need, protective gears, to make sure they, you know, as a duty of care, we don't put them at risk first. Next slide. So as my colleague from NRC said, we also work to the community centers. And how we do this is because community centers in Somalia, in all the sites we're working in, it's community-led. We are not managing it, it's the community leaders, different committees in place are the ones managing the community center itself. And it's a central part of IDP in a cluster of an area. So for instance, you have like 10 IDP sites with that number of population, despite having the, you know, the local under a tree where they come together at every site, we still have this at least big structure that is in place, that is led by the community themselves, and they have a way of dividing their time. They hold their trainings, where they hold the meetings, all the other relevant information that is needed, be it times of distribution of things like that. Messages are passed through this center. Like, so it's very important that it keeps open and running. So what we thought about is how to maintain this center that is very important, while it's observing, you know, making sure that it doesn't contribute more further to the spread of COVID-19. So we only decided to conduct small awareness sessions at this community center where we have less than 10 persons. So in every gathering or, you know, awareness session that we are conducting at these centers, they are conducted at a maximum number of people of 10. And we've made sure that at least we use the site leaders, the religious leaders, influential people to come at least to get the first-hand information. They can go back to their blogs, you know, and pass this information. Sessions target these community leaders who we know at least can go back to their blogs and pass this information. So what we do at these sites is normally we have adjacent to it the CFM desk, areas that the site management staff can come and sit and directly deal with beneficiaries. So we have about maintaining this as well, this desk. We address rumors, talk about hygiene promotion, do you know, direct you know, hand washing, you know, how to do it. We make sure that we have a good ratio of both male and female attendees, and our staff, frontline staff, the most integrated mobile outreach also operate from this area, making sure that at least we observe this. As you can see in the picture, we also have messages that are sticked on the billboards, and communities can read both in the different dialects within Somalia. We have quite a number of dialects, and this is captured. Next slide. So this is an example of our community center, and trying to show the 1.5 meters this social distancing to just give an idea of how we do it. Next slide. This is also another bigger one with, depending on the number of the size of the center in itself, like this is a food distribution site that we've used it as well to pass information through the outreach stuff. Next. So, like I said, the mobile outreach teams have been very, very, very critical during this time because everyone is talking about risk communication, and community engagement. And this is the way. So what we've done is the CCCM teams are integrated with key clusters, health and WASH specifically, visiting sites and conducting awareness. Site leaders and key informants are, we use them, they work with us to pass this information. From the onset, we had megaphones that we use normally during our awareness activities. They've come in handy to spread more information in areas that, like you just stand in the middle of site and you can pass into several households instead of calling them in one area. We've increased, to maintain social distancing. We've also introduced a modality where we use vehicle-mounted loudspeakers as an alternate to social distancing, also to pass more info. So it goes around, it covers more area. It goes through the site without, coming into contact with anyone, and pass information this way. So the megaphones, one-on-one, very limited, and using the vehicle-mounted loudspeakers. Next. In every IDP site, there are community common areas, be it a school, be it a market, be it where they learn Quran. And these are sites, apart from schools, these are still operational. They have not been closed. And I can assure, the team now also make an effort to go to water points, markets. So this is a picture depicting our teams walking inside the market stalls. As you can see, they are a bit of distance. Normally, they are congested coming together to save, the space, but now they've moved their carts where they are selling the produce, so that at least the message is getting through. Next slide. Yes, this is under a tree, one of the common areas that Somali IDPs use to sit under a tree and talk. So through the CMCs, we also sit down in the committees and try and pass messages, because they're very, very good at passing information to other community members within the IDP side. So they invite us, we have the schedule of the meetings, and ad hocly we do sit down and talk to them about the risk and what they can contribute as a committee, or to pass the information. Next. So what happened is sometimes when an onset of an emergency like this or a crisis, sometimes you tend to forget, what the other core activities. There's another speaker talking. Maybe you can mute your speaker microphone until we finish. Thank you. So other core activities that are still ongoing, which are equally important, as much as passing information to and awareness raising. So what we've done is, through the CCCM cluster in Somalia, we've coordinated and come up with ways of our teams to continue doing key cluster activities or key CCCM activities, including service mapping and monitoring. These are handed over to site level focal points who have been trained at collecting partners information. We give them the tools and they do collect this information. For now, we still have access to sites and we can have one-on-one and continue to do this with them. Partners are requested also to daily report or questionnaires and templates, anything that issues coming up. And also part of the monitoring, we, as I mentioned earlier when we were starting, most of the IDPs are living in public-private land. So part of the work that the teams are doing is also to monitor any eviction threats that are coming. In Somalia, eviction is one of the #1 protection concerns that we have. And through our HLP partners, community leaders, local authorities, this is monitored to make sure that at least it's reported on time, to avoid, as much as it being a protection concern, it's even more worse during this time of COVID-19. On complaints and feedback mechanism, we didn't so much use the hotline before. We felt it's more practical on one-on-one session, having CFM desk at community centers inside within the community, where our teams who are trained have a one-on-one communication with partners, communities, and also feedback goes back and forth. But now, given that the room to operate is getting smaller and smaller, we've now adapted to use a hotline, which is very free. And communities are able to both send SMSs, call in. We have trained our team on how to take messages, take, calls, recording them, referrals, also, when the case is closed, getting feedback from both communities. So we are maintaining both as of now because community centers are still open and we are not in total lockdown. So we are both employing both systems. So this way we think by the time we have a total lockdown and our teams cannot go into the site, our communities are now familiar with this new mobile number or a hotline or toll-free line that is operational. So this way we will continue engaging with the community. Next slide. So this is just a sample of the toll-free line poster. It's also translated into the local dialect and is placed in all community centers where relevant, where communities gather to at least get understanding of the new ways of communicating with us. Next slide. Site maintenance activities, observing social distancing. We have stopped site maintenance activities, but especially in Somalia now, we are in the good rain season, where most of the IDP sites get flooded. So if there are critical, community-led maintenance work that is needed through CMCs and site management committees, these are, continue because they're critical, and as much as you want to maintain, social distancing and all things like flooding, we need to make sure that drainage system are working and all this. So we provide tools and we coordinate with community leaders to make sure this is ongoing. But all the major site maintenance activities have stopped. District level ad hoc site level coordination meetings. Site level challenges are recorded by partners remotely through telephone and coordination, and this is taken up through our coordination meetings. So since we still hold the CCCM, both site level and partners meetings, monthly meetings, these do come up and addressed, and also feedback given back to communities through the channels that we've put in place, including the talking to community leaders, specific person who referred the case, and we make sure that cases are followed up closely. Continue. Next slide. So for now, what we are prioritizing for the risk communication and community engagement, what we are considering, because we have so many sites and we don't have so much time until local transmission and lockdown happens, is we're considering large IDP sites hosting this number of IDPs. Are the sites that have capacity sites that at capacity with no room for overflow? Are these areas where there is no adequate space to walk between shelters because of congestion? Bull makeshift, the makeshift shelters, we call them bull in Somalia, shelters primarily used on this site. Is there an potable water source available for residents to use? Is there a health facility available? These are risk factors putting more pressure on these particular sites. So we give priority to these ones, not neglecting other sites, but we go to these ones. So you need to reach 500 of them sites. So we start like the bigger ones, which are congested. This way, at least we come down to the level where we've reached almost all the sites. Next slide. So again, we're using small group discussion. We're using radios and loudspeakers, household level conversations, IBC billboards and posters. And so far, at least according to the cluster, we've reached more than 700,000 have received information since we started. And this goes to show that at least, coordinating together with other, clusters and line ministries and local authorities gives you a bigger team where you can divide yourselves and reach more IDP sites. Next slide. Just to summarize, this is, I think, my last slide. Is the way we're working right now is we've integrated the teams that go out. We have updated key informants contacts, but including also every relevant committee, every, like religious leaders, we have all their contact details because it's inevitable. It will reach a point where we will have to do this only remotely, and we don't have total access. And they will be the ones who are reporting, monitoring services, referrals and all this. Site management should be conducted through site leaders, work closely with local authorities, landowners, and HLP partners to reduce the threat of evictions. Use of toll-free numbers to conduct a complex grievance mechanism in case of total lockdown. In the meantime, integrate the current method that you have plus the new one, so that at least by the time you can't access, they are more aware of this. Of course, like in any other awareness session that we do, translate key messages to the local language. Make sure that your team understand it, and also they can, share this information. Frontline staff are protected and trained. Update all referral pathways, including areas that are set for isolation. Get updates on Ministry of Health and how WHO are conducting isolation centers. Next slide. I think this is the last one. Yes. So for me, I will stop here and looking forward to your questions. We in Somalia right now, we have about 237 cases confirmed, and we hope it doesn't go to these sites. Otherwise, it's going to be a really catastrophe. So thank you very much.
Thank you very much, Abu, for your presentation, and thank you for Matt. And maybe I can ask you both to switch on your camera. I think it seems to be working, so we can look at some of the questions that have come in. Great, thanks, Matt. So I have here a question from Jennifer for Matt. And she's asking if you could describe how you're maintaining confidentiality on protection issues through the NSC call centers or call mechanism you have set up for the COVID.
Thank you, Jennifer, for the question. So there is not many changes in the referral confidentiality mechanism comparison to normal situation, because we already have these hotlines for referrals. But when it comes to protection issues, so there is usually people can know already whether they want to talk to a male or a female, which of course doesn't solve all the confidentiality issues, but it's probably the biggest factor that prevents people from calling in many occasions. And then a problem we have with COVID, which is specific to COVID, which we cannot really deal with fully, is that we are not allowed to store any health data. So if someone, for example, would call us saying that he or she believes to be infected by COVID, then we will refer that, we will either give that person number or call someone so that this person is called, but without providing specific health information, and certainly without storing any specific health information, because we are not allowed to do that. Yeah.
Okay,
I hope this responds more or less to the question.
Thank you. Jennifer, please feel free to unmute your microphone and add anything if you want to. Also, other people please do. I think we are not such a large group in the end, so I think it should be possible. So, Abu, maybe the next question would be for you. Let's see what he says from Susanna. And how are you providing adequate monitoring and oversight with, oh, I think this is still for Matt. Sorry, Mate. So how do you provide adequate monitoring and oversight with virtual and remote implementation? Mate, maybe I can ask you still this one.
Yeah, sure. If we go in fully remote, then we are going to be monitoring through the smart LRM system through messages, so asking questions for surveys and monitoring, and through the focal points, male and female. So we have delivered the phones with top up to female focal points, because our issue was that actually, interestingly, almost every household has a phone, but has one phone. And usually this phone is owned by the head of household, who is usually a male. So in order to monitor a little bit more and better and have an access to the issues that will be happening to females, or how they feel and what is their feedback, we had to give. And well, the challenge is how to monitor that those phones that we distributed for monitoring are not being taken by the heads of households. But at some point we have done the awareness, we have gone through this. So this is what we are going to use, focal points and messaging and this communication.
Thank you, Mate. Abu, would you like to join something?
Yes, it's the same thing as Matt said. We are also, in case of total lockdown, we're providing solar charge batteries and megaphones and mobile phones to the community leaders to be placed at community centers. But our hardest way of monitoring that this is used by all the community and not just the community leader taking it without is way of, for us, like we were thinking, yeah. But what we've decided is we've called all the relevant committees in the community, in the IDP sites, and informed them that these are going to be used, charging your phones and all this, and it's a central thing for all the community. This way, it sort of removes the community leader taking it to his house alone, but rather it remains within the community center itself. But yeah, it's a thing that we're trying to see the best way of handling that. Yeah.
So if I may, one thing, I don't know how complicated it is in Somalia, but I guess it's similar, because we have a very big corruption among community leaders, like in terms of appropriation of resources and manipulation of and many of them are even very good at kind of responding in a way to assessments that they get more aid, because they are just, unfortunately, after 40 years of war and many crises, they know very, very well how the system works. So this is why we are trying to kind of distribute as many, like identify more focal points and make this communication bigger, because otherwise it's not really reliable, the data that we can obtain. Adding on that.
No, it's the same with the community leaders in Somalia. It's the same. Yeah. So yeah, we're using different committees to distribute these resources, sort of making it more clear among everyone. But yeah, they've been in this system for a while, and they know ways even to navigate and take advantage of these resources. Yeah.
Thanks very much. We have a different kind of question here coming in from Donald. Which is, how are you preparing the camp community to deal with the outbreak of COVID within their community in the camps, knowing that the local health system will most probably be overwhelmed very quickly? And so what advice or guidance do you provide the communities what to do? I hope I understood the question correct, but I think so.
I think what we are doing right now is, it's inevitable. Even in big cities, we find the health system is overwhelmed. We are talking about more than 500,000 IDPs in one location with few health facilities, no isolation centers, no ventilators, and so what we are doing right now is to provide as much information as possible to communities to prevention, so that at least they're aware of what to do, where to refer, and making sure that they understand the importance of hand washing and all the guidelines that have been put in place. But I agree. I mean, the system is going to be overwhelmed. But the way we are doing it in Somalia right now, we are not going only as site management organization or CCCM. We are with the local authorities, the district, the mayor's office, the governor's office. We have the IDP commissioner's office. We have the health ministry and health clusters. So sort of, working together with the community leaders and different committees within the community to prepare them, sort of. But yeah, it's a good question. Now, happy to hear from the rest as well how it's being done in other areas. But here is just to provide risk awareness so that at least communities are better prepared.
Yeah, I think from our side. Yeah, thank you. Sorry, from our side, regarding the main measures that can be taken, so which is what Abu said, we are emphasizing a lot everything that is hand washing and hygiene and etc. The problem, of course, is the supply of water. We are, of course, delivering the whole package of measures that can be taken, but we have to understand the context, because social distancing being impossible in practical terms, and even hand washing being very challenging in many cases. On the good side, this situation has allowed us to be very efficient in advocacy towards the WASH partners. We have been asking since 10 months to dig some boreholes and provide water, and now they are like, yeah, let's dig boreholes because the people need water. We are like, yes, and they need water since 10 months. But so that's maybe the good side of it, that we are being able to really push the WASH sector to more engagement and different actors. But we are also recommending and emphasizing a lot to keep social cohesion and calm. We are talking about a population, at least in our case, which is quickly complaining for very legitimate reasons, but sometimes violently. And we are trying to keep the situation more or less, like to keep this non-stop communication. But if the food insecurity increases, then there will be trouble. So we are trying to deal with that as well. We are going to be distributing this cash soon. Yep.
Mm-hmm. Mm-hmm. Thank you. We have one more question from Chloe, which follows on from the regarding preparing the communities to deal with the outbreak. Is there actually any access to testing available to COVID? And are the numbers of the cases within the site monitored, or the national statistics? I think, please go ahead, either of you.
At least in Somalia, apart from the main capital city, Mogadishu, there are no other testing sites that we are aware of. And for instance, like the region that I'm working in, we had 2 suspected cases a week ago. But because of the incident management system that has been set in place, both with the line ministries and WHO and partners, and clear referral messaging and cases, 2 cases, suspected cases, were identified. Within a day, they were airlifted out, and thank God it came out that they were negative. So no testing sites for even the whole region that we're working in. Only when we have suspected cases, or the Ministry of Health and WHO, it's referred to the main capital, Mogadishu. But yes, we don't have this, and we hope that this is why we keep on pushing and messaging to make sure that at least hopefully it doesn't get. And good thing that the government has now limited transportation between these 2 major cities to sort of reduce that risk of intercity transfer.
Mm-hmm. And Mate, do you have any?
So yeah,
responses?
in 2 of the 4 regions we work, we have some testing capacity. The government has, and we are referring people. So we are able to identify suspected cases and refer them. Now, very often we don't have like the feedback very clearly, at least at the beginning. Now it's more clear of who is positive, who is not, because also like the main problem we are finding, and that's another important point of awareness, is that the almost anyone who is suspected to be infected will rather stay home, and they don't want to go to the hospitals because there is a whole set of rumors about being killed in the hospital and about the hospital. And this is happening since the beginning. And this is, on the one hand, now that the hospitals are starting to become collapsed, it's not necessarily bad if someone has mild symptom stays. But we are being very careful because only a confirmed case, it's a confirmed case. And people are running around saying, oh, he or she has COVID. And this with the very high morbidity rate anyhow in the sites, we have to be careful not to propagate rumors and overreact to that kind of. So when we report someone, we report like X or Z person has been reported as having symptoms, or not a person but a case, and has been referred, and then we see if there's a
Well, that actually leads me to a question which was sent in earlier, which was referring to stigmatization of people who live in the sites, that they maybe have contracted COVID, and what will that do to them, and what programs or what do you do to address that, if there is something you can do? Mate, do you want to, or Abu want to?
Sure.
Reply?
So I think there was more stigmatization perhaps at the beginning than now, when it was more a more far away reality. Then we have been working a lot in awareness in the sites on this, and there is obviously more fear now, but our impression is that as the cases have been expanding, the fear has increased, but the stigmatization is a bit lesser, perhaps because people kind of maybe have accepted this as a sort of reality, and hopefully also because our communication has made some effect. Yeah, they have suddenly realized that anyone in the community could be affected. So it's kind of less. It's not a good situation to stigmatize when you know that you can't get it any moment. Yeah.
Yeah. Abu, would you like to?
I totally agree with Matt. And now that people have now realized, oh, that family and your family, they have a suspected case, or someone has in their family in another city has reported. Stigmatization as far as COVID is concerned has gone down, but the rumors still tend to continue. Like you find that, oh, we are Somalis, we are Muslim, this one is not meant for us, it will not, reach us. These are, some rumors that are very much, reducing what we've been doing, trying to raise awareness. Yeah. So we've sort of now, if you're saying, okay, now you're a Muslim, you cannot get this, it's a Western thing. Yeah. So we're using the religious leaders to sort of now, engage with this particular community, and also making sure that they understand that this is just as any other disease that anyone can get. And so awareness raising has really, really helped in reducing, by using key influential individuals within the community in reducing stigmatization. Thank you.
Right. So there was also a question which came in before, but I think it links a little bit to what we have been discussing. It's like you've been describing how important it is that you have that your frontline staff has a very close trust relationship with the community, maybe established over very long periods of time. And how important is that trust relationship now when you suddenly don't have face-to-face contact anymore and you have to go virtual? How important is that to have that established before you, in a way, go into this kind of virtual mode? Mate, would you like, or Abu, please?
Yeah, for sure. I mean, I think when you're working in a CCCM, like in a camp setting or site level, one-on-one communication is really the key. Being in the center of community, talking to them, and so that trust has been built over time. And even before, let's say the community leaders, the different committees had ways of contacting us, even during the weekends or during when our teams are engaged in our areas, they would be able to come back to us. So it goes back to how, before even this crisis, how well were your site management staff, how your teams were in coordination with the different committees, different leaders and community members, how well were they engaged in the first place to build that trust? So if you're working to build the trust now through operating remotely, that will never work. But if you had this trust in place, you've been working, they sort of believe what you tell them, even if you're not there face to face. So they call different calls for different services. They know where to, refer. They know who to talk to directly. As much as we introduce a new phone line free, but they also have the different contacts of different members of our team, that outreach team, site management team, our WASH coordination team, all these teams, they already have these contacts and they're able. We've already had an open-ended communication with the different IDP sites. We had a good ratio of the team and the number of sites they cover. So this way, that stress of calling and not getting answers and things like that is a bit reduced. So it also boils down to what measures you have put in place in the first place before this crisis, and now how you have updated your contact list, and now they can still use those same platforms to reach you. Over to you, Matt.
Yeah, thank you. I think I totally agree with that. And in our case, there is a concrete example of how that can have an impact, because we opened a center in the north in the 1st of April, and that's the only center where we have had an issue until now, in terms of people just arriving in hundreds and not being able to control, where we have a small team as well there. So we had to close it for 2 days. The time of course, is not directly related to the trust, but it relates, yes, to the capacity of reaching out to the if you tell them just stay, and they know you, then you stay. But if they don't know you, then they will keep coming until they make sure that they know you, and then they. So this is, it's interesting. It's fundamental, and this is something that I think remains misunderstood. The importance of the trust with the community and the relationship. In many cases, it remains not a subject of. It's not a priority very often. I see it. Like, you just go, you deliver, you leave. We delivered the 1,000 latrines. It's fine. It's okay. Like, that's it. But then how you will the after and the whole process, right? Yeah. Always.
Yeah, thank you so much. And actually, Brian sent in a follow-up question, and which is like, how has high level of rumors and need of risk awareness and social distancing measures affected the camp management ability to maintain the trust of the people inside? So, looking at it from the other side. I don't know, Mate, maybe you want to quickly respond as you're already on the topic.
Sure. Yeah. So it has affected, because rumors. I mean, Abdu just mentioned as well, and we have the same rumors. Like, Muslim people will not be affected. This virus is not created for Afghans. It's by the Chinese for the Americans, or vice versa. The virus doesn't. I mean, if you pray in this and that way, or you drink this and that, or you recite a surah, then you are safe. So I think these rumors will continue forever, because these rumors are also spreading in Europe, by the way, and in many other places, similar rumors. So, but I do think, however, that with time, again, a little bit like with the stigmatization, people are, perhaps they still believe in rumors, but they are paying more attention at what we do and at what we say, because they are seeing the effects. And they are seeing that what we say is true, because they are seeing their neighbor getting sick in the way that we say the person will get sick, and recovering, most of the cases, in the way that we say. So with the time passing, people are more directly confronted to this reality, and even though they may still believe in rumors, they kind of pay more attention to practical guidance, which is what we give, yeah, because that's at the end what will matter.
Yeah, thank you. Abu, do you have anything to add?
Not so much. I mean, this is the same. I concur fully with Matt.
Yeah. Well, we have one final question here from Susanna, which you maybe can see too. Have you faced challenges of organization promoting de-disinfection, and what are the most appropriate alternatives? Or do you have any experience in that? Abu, do you have
Could
any?
you repeat the question again?
Yes, sorry, Susanna just highlighted too. So, have you faced challenges of organization that promoting de-disinfection, and what are the most appropriate alternatives?
De-densification.
Oh, she's just corrected. I'm so sorry. De-densification. Yes, we had this. We had this question also before sent in. It's like, what about changing the physical environment, in these overcrowded settings, removing or separating people? And do you have any experience on that, Abu?
I must say, in Somalia right now, no. People are not separated. Because we have not received cases that are within the site so far. But yes, I would imagine it will be an issue, and the government is making sure that we have areas set. But given that people are residing in private land, there's not much room for this. But we don't have much experience on this, and it's a learning experience for us as well. But yeah, I would be happy to hear from Matt if this has happened in Afghanistan.
Yeah, thank you for the question. De-densification is the first time I hear this term, but after thinking a little bit about it, I understood the meaning and makes sense. We haven't had any organization advocating for that. Obviously, physical distancing, it's one of the key protective measures. It's impossible to implement it at a household level. The only possible way of implementing this will be to send people back to their areas of origin. Or at least that will carry other problems, and it's not feasible either. The only thing we are considering, if the situation keeps getting worse, is that we have a separation of the people who are at risk, eventually some categories, and providing them possibly some sort of different tent. We have RHUs, refugee housing units, and we have a number of them, and we are going to get in touch with the community and with some service providers to know better their advice on this, whether it will make sense for us to, it's not a de-densification, but is a kind of pulling a little bit away from the main population, people who are more at risk. But yeah, this is the only thing we are eventually contemplating.
Thank you, Mate. There's just one last question coming in. I think we have time for one final one from Chloe. Do you think it would be worthwhile to have an in-depth research proposal or following this epidemic to consider how spatial morphology of informal settlements has impacted the vulnerability of the residents? So in terms of physical space and density, and maybe also living patterns or household patterns. I mean, I'm interpreting a bit, but I think this is what is meant. How families live together, for example, in one room or by different generations. Would you think that would be something useful to study closer after the epidemic is over? It's a very theoretical question, but maybe it'd be a nice thing to think on.
I think.
Go ahead, Mike.
No, sorry, please go ahead.
No, I think as of now we're not thinking about this, but yeah, I mean, if the pandemic ends and we are corona-free, and yes, it's something worth looking at. But again, I would think of how impactful is it going to be. I mean, informal sites are going to be there. They keep on coming. These have more correlation with political and social and all these other factors. So yeah, I mean, if someone has money for this to do this research, it's more welcome. And I would think it will help understand the dynamics within the within the household level in these situations. But yes, at this time we are focusing on making sure that we reduce the spread and as much as possible.
Yeah, I think that a lot of research will be done after this crisis in many different sectors, and this is finally not too different. Is an epidemic, so it's not too different from another epidemic that could have happened from another disease, and others will come. And I don't know if specifically for corona, but in general, the study and the understanding of the spatial morphology in terms of resistance to epidemics is interesting. I do think, however, that there are so many factors. One challenge will be in such a research that there are too many factors. Spatial morphology is one. So how much is the impact of this factor, and how can you certainly deduce that the impact is this in comparison to other factors, million of them, no, weather, general health status of the population, which is very difficult to measure. In some cases, water, etc., etc. So a lot of factors, and this will be one of them. And then, of course, in sites, we will always have this problem of finding trustable data, especially after, because who has had the COVID, how, up to which extent, yeah. So, yeah, but interesting.
Okay. Yeah, thank you, Mate and Abu. Thank you so much for your time and all your efforts to come online today and share your experiences and what you are working on right now. We are kind of coming to the end of the webinar, but Abu, do you have any final remarks you would like to make? You know, maybe something that you find is really most pressing to share?
Annika, thank you very much, and the team that has organized this webinar. I mean, like I said in my starting few statement, was that we are all learning. It's a new way of working. The most important thing that I would, if anyone would take away from this session for me, would be one. As much as we work remotely, remember that we have communities in place. Update your, referrals, update your contact list, because at the end of the day, we will not be able to go if one case happens in IDP sites or, collective centers. We will definitely not be able to go. Protect your frontline staff. At the end of the day, as much as you want to work for the community and pass information, try as much as possible to make sure your frontline staff are protected. And lastly, coordination is key. At the end of the day, you cannot work alone. What has worked for us really, really gratefully is that you have the government authority, you have different clusters like Meta said, WASH cluster, health cluster, all these working together at site level, sending the same information, given the amount of rumors that are spreading. This is really, really key. And we do hope that we will be speaking sometime in the near future about lesson learned and COVID-19 is done. And I wish that everyone stay safe and keep safe. Thank you very much.
Yeah, thank you, Abu. And Mate, do you have anything final you maybe want to add or elaborate?
No, thanks. No, just to thank everyone for their participation on the questions. It was very interesting to listen to Abu as well. I think just a reflection for me, which is maybe as a last reflection, which I am finding difficult in these last weeks, is the protection of our staff, as you mentioned as well, in a very uncertain situation. And it's not a security kind of context or a natural disaster context that we are used to, and in which we know more or less until where we can push our staff, what we can ask from them, what we, of course, subjectively always consider more or less safe. This is subjective, I think, overall a little bit as of now. Maybe in 1-2 years we will know more exactly which were and which are the dangers. We don't know very much, actually. We know, but we don't know everything. We know a little part. So in this situation, it's a tremendous responsibility to work and make work the team. And the teams and the same trust that the beneficiaries are kind of putting into our teams, the teams are putting into us as managers, because I guess most of us in here in this discussion, we are managers or managing teams or manage teams, and it's not easy. And I do hope that we can keep reasonable in this situation and understanding the consequences of our decisions. But our strategy until now has been to stay and deliver, and up to the reasonable. If there is something like that now, we will try to stay and deliver. And if anyone wants to contact me, I don't know if my email was there, but if some questions or exchange of information or tools, happy to contribute to that as well, of course.
Yeah, thank you. Thank you to both of you, and thank you, Mate, for offering that. We will follow up with an email, and then if you're happy to, we'll share your email addresses. And just before we close, I would like to just quickly say that next week we will have another webinar within the same series, in the CCCM COVID-19 series. And if Brian is here, if you would like unmute and give one sentence about what you are thinking of doing next week, then please go ahead, Brian.
Sure, thanks, Annika. We're going to send out a brief introduction to the session on Thursday, but just to know that you can keep track of the details on the CCCM cluster website, and we have a registration link up there as well. So as soon as you register, you'll be sent the link to join. So hope to see many of you same time next week.
Thank you, Brian, and thank you everyone for staying the whole 1.5 hours and participating so actively in this webinar. And well, I hope you all will be staying well and healthy. If you want to get in touch with the CCCM area-based working group, then please do email us, and we'll be happy to hear more from you. So thank you very much, and I hope everybody will stay well. Bye-bye.
Bye.
Bye. Thank you.
Thank you. Bye.
Hi,
Thanks,
guys. Thank you very
bye.
much.